Hello and welcome to my channel. I am Dr. M.D.Zafar and I talk about the core concepts related to the IMM surgery and allied for FCPS and MS candidates. Today we are going to talk about hypertrophic scar. So a hypertrophic scar is an abnormal response to wound healing process which will be followed by an excessive collagen deposition. Now this is the very important point, which will result into a raised, thickened scar, but it will remain within the boundaries of the original wound. So this not only describes what a hypertrophic scar is, but it also explains the pathophysiology. I will talk about this in the pathophysiology. So what are the key factors related to the hypertrophic scar which can be asked in the MCQs? It is a raised red or pink scar. It lies within the wound margins, unlike keloid, which is the counterpart of hypertrophic scar, which extends beyond the boundaries of the wound. It may also result into itching or tenderness and can also present with some cosmetic concerns as well. The common site of development of a hypertrophic scar is the area of skin tension or movement that includes the joints, for example, shoulder joint or any other joint, and over the chest. Now, it nearly always develops after a deep thickness burn, and one of the possible outcome is the contracture formation. So it usually develops within 4 to 6 weeks of injury. So these are the key factors. Now we will talk about a bit of the pathophysiology and treatment for hypertrophic scar. So talking about the pathophysiology, there is excessive fibroblast activity and collagen is deposited. Now the difference is that in normal process of wound healing, in the proliferative phase, collagen type 3 is deposited. Later on, in the remodeling or the maturation phase, it is replaced by the type 1 collagen. But if that type 3 collagen is continuously being deposited by the fibroblast in the proliferative phase, that will result into a hypertrophic scar. So this can be triggered by delayed healing, infection, tension on the wound, which is very important factor, and genetic predisposition. The risk factors include young age, dark skin types, burns or deep thermal injuries. This is one of the very important risk factor for developing hypertrophic scar, and poor bone care. In terms of the management of hypertrophic scar, first of all, we have the non-invasive management, which include silicone gel sheets, pressure therapy, which is especially common in burn, and topical steroids. Now, these topical steroids will reduce the inflammation and excessive collagen synthesis. Second, we have some minimally invasive procedures like intralesional steroid injection, followed by laser therapy. Thirdly, we can excise it, but it is only done if there is some cosmetic or functional problem associated with the location of the hypertrophic scar. In terms of prevention, minimize the tension on the wound while performing the suturing. Excessive use of silicone sheets in high-risk patients can be helpful in prevention of hypertrophic scar, and avoidance of the sun to the site of injury can prevent formation of a hypertrophic scar. So now we will talk about the keloid. Keloid grows beyond original wound margins. However, hypertrophic scar remains within. In keloid, there is a genetic predisposition. It is especially found in the African Americans, and the genetic link indicates that it has an autosomal dominant genetic link. Now, keloids do not regress naturally. However, hypertrophic scar can usually result into disappearance, but keloids do not regress. And the common keloid sites include ischium, sternum, trunk, and sacrum. There is a key anatomical point, that is the triangle formed between the xiphisternum and the two shoulder tips. This area is prone to keloid formation, especially after injury. Talking about the treatment for keloid, the first line treatment for keloid is an intralesional steroid injection. However, for recurrent keloid, excision plus adjuvant therapy with intralesional steroid or radiotherapy can be the management. But if the MCQ says that what is the management for the minor keloid, then silicone gel in association with intralesional steroid injection could be selected. So now I will talk in the form of a diagram which is relevant to solving the MCQs. So I have made this diagram to help you visualize and guide you through the MCQ management. So in the hypertrophic scar, the first line management is topical retinoids followed with pressure therapy. So at the MCQ states, what is the first line or the best therapy for hypertrophic scar, then you can select these two options. However, if these options are not available or they are stating that what is the second best treatment for hypertrophic scar, then intralesional steroid injection followed by surgical excision will be the answer. Talking about keloid, if there is a minor keloid, then steroid injection, cryotherapy followed by silicone gel therapy can be the management. However, either they state that there is a major keloid or they can state what is the first line or the best treatment for any keloid. Then that answer would be intralesional steroid injection. However, for recurrent keloid, surgical excision along with intralesional steroid injection will be the answer. So I hope I have cleared your concepts regarding hypertrophic scar and keloid, and this will be your guide to solve MCQs effectively. So thank you very much for listening.